Atrial fibrillation and flutter. Brief description.
Your heart can beat chaotically without you even noticing. This is atrial fibrillation, where the upper chambers of the heart quiver irregularly, sending mixed signals to the ventricles.
Atrial fibrillation, AFib. Marked by disorganized, rapid, and irregular atrial activation. Results in an irregular ventricular response. Ventricular rate is usually rapid. ECG characteristics.
On the ECG, AFib shows no distinct P waves and an irregular ventricular response. The heartbeat is unpredictable and often rapid.
Lack of P waves. Irregular ventricular response. Narrow QRS. Atrial flutter, AFL. Characterized by a regular rapid atrial rate of 260 to 300 beats per minute. Usually results in a regular ventricular response in a 2-to-1 ratio, heart rate, 130 to 150 beats per minute. Ventricular response can sometimes be 3-to-1, 4-to-1, irregular, or rarely 1-to-1. ECG characteristics. Sawtooth appearance of the baseline, mainly on inferior leads. 2, 3, AVF. Rapid, regular, and narrow QRS.
Atrial flutter, on the other hand, is more organized. The atria beat rapidly, but in a regular rhythm, creating a predictable pattern. Its hallmark is the sawtooth ECG waveform, usually visible in leads 2, 3, and AVF. Ventricular response is typically regular, often in a 2-to-1 ratio. Treatment for both rhythms focuses on controlling heart rate, preventing stroke, and addressing underlying causes. Options include medications like beta blockers and anticoagulants, or cardioversion if the rhythm is unstable.
Treatment. The management of AFib and AFL are the same. Objectives of treatment: controlling ventricular rate, prevention of thromboembolic events, identification and treatment of the cause, identification, prevention, and treatment of precipitating factors, non-pharmacologic, avoid stimulants, e.g., caffeine, CAT, and alcohol intake. Immediate electrical cardioversion. Indicated for hemodynamic instability, cardiogenic shock, due to a rapid ventricular rate. If hypotension occurs at ventricular rate less than 130 beats per minute, investigate other causes. Energy, usually 100 to 200 joules, must be synchronized. Pharmacologic. Acute ventricular rate control, first line, metoprolol, 2.5 to 5 milligrams IV over 3 to 5 minutes, up to a maximum total dose of 15 milligrams over 10 to 15 minutes. Alternative. Digoxin, 0.25 milligrams IV Q2H until 1 milligram total. Note. Digoxin is the first line if AFib is associated with severe left ventricular LV dysfunction. Chronic ventricular rate control, first line, metoprolol, preferred beta blocker in patients with heart failure and depressed LV systolic function. Immediate release, 25 to 100 milligrams twice daily. Extended release, 25 to 200 milligrams per day. Or atenolol, 25 to 100 milligrams PO daily. Alternatives. Digoxin 0.125 to 0.25 milligrams PO daily. Can be added to a beta blocker when rate control is suboptimal. Preferred agent when heart failure due to LV systolic dysfunction is not well controlled. Or verapamil, 40 to 80 milligrams PO, 2 to 3 times daily. Anticoagulation to prevent cardioembolic cerebrovascular accident, CVA. Risk stratification, CHA2 DS2 VASC or CHADS VASC score. Used to estimate annual stroke risk. 1 point each for heart failure, HTN, age 65 to 74, diabetes, female sex, vascular disease. 2 points each for age greater than 75, history of CVA. Indication. Anticoagulation is generally indicated for scores greater than 1, unless high bleeding risk. Choice of anticoagulant. Warfarin only, for patients with mechanical valves, mitral valvular disease, or ventricular assist devices. Direct oral anticoagulants, DOACs, can be used for other patients. Include factor XR inhibitors, apixaban, rivaroxaban, edoxaban, and direct thrombin inhibitors, dabigatran. Do not require laboratory monitoring. Dose adjustment required for renal failure, elderly, low body weight, and high bleeding risk. Warfarin requires mandatory INR monitoring, goal INR 2.0-3.0. Starting dose 2.5 to 5 mg per day, titrated to goal INR. Goal is to maintain time in therapeutic range, TTR, above 70%. Bleeding risk assessment. A discussion regarding anticoagulation must include an assessment of bleeding risk using the HAS-BLED score and shared decision-making. HAS-BLED score assesses hypertension, abnormal renal/liver function, stroke, bleeding history, labile INR, elderly, drugs/alcohol use. Selection. Individualize the choice, warfarin or rivaroxaban, based on risk factors, cost, tolerability, patient preference, potential for drug interactions, and TTR history if taking warfarin.